From Axxess, this is Jennifer Gibson. I'm a registered nurse and I'm coding and OASIS certified, and I'm here today to present to you part 10 of our 12-part coding series called Navigating the Highway of ICD-10-CM. Today's topic is coding complications and injuries. Our objectives today are to understand why proper coding is important, to learn who's responsible for applying and assigning diagnoses, to study guidance for coding complications and injuries in ICD-10, and then apply that knowledge to common home health scenarios. As a brief refresher, we're going to talk about who selects the diagnoses on the OASIS and who actually codes those. But if you want more information on this topic, please go back and refer to our first part of the 12-part series, where we'll go more in depth about the selection of diagnoses and who should actually do the coding. So according to the OASIS C1 Guidance Manual, selection of primary and secondary diagnoses must be made by the assessing clinician. What that means is that the clinician in the field is expected to do an assessment and understand that patient's overall medical condition and care needs before selecting the diagnoses that belong in the primary and secondary diagnoses positions. Now, those diagnoses, of course, are based on the assessment findings as well as the medical record and input from the physician. Also, according to the OASIS C1 Guidance Manual, the assessing clinician should then record the primary and secondary diagnoses in the OASIS items M1021 and 1023, respectively. The coder then can come in and add the actual ICD-10 code, but it's the assessing clinician's responsibility to determine that primary and secondary diagnosis and the sequencing. In order to select primary diagnoses, you should know the criteria for that primary diagnosis. That criteria includes that the primary diagnosis is that diagnosis that's most related to the current plan of care. And if more than one diagnosis is being treated, it's the diagnosis that represents the most acute condition and requires the most services. In other words, it's the chief reason for home health. It's that diagnosis that requires the most intensive skilled services, and it's not a Z code unless absolutely necessary. Now that we've covered the primary diagnosis criteria, let's look at the criteria for secondary diagnoses. The secondary diagnoses are those diagnoses that didn't meet the criteria for primary diagnosis, so we know they're not the primary reason for home care, for example. But these are diagnoses that are addressed in the plan of care and diagnoses that affect the patient's responsiveness to treatment and rehab. Now, the list in the secondary diagnoses, you may have 1 or 2, or you may have 6, you may have 7 or 8 additional diagnoses. So in order to reflect the seriousness of the patient's condition, you're going to adjust that list and put them in order from the most acute, or the ones that need the most services, to those that need little services or perhaps just assessment. They will also help to justify the disciplines and the services provided. So that's how you're going to consider the order in which you put those secondary diagnoses on your OASIS. Some general guidelines you need to remember is that regardless of how long you've been coding, when you start to look up a code, you should always reference a code book. The reason being that when you look up a code online, primarily you're just choosing from a list of code titles, and you don't have the context of any kind of coding guidance, any kind of inclusionary or exclusionary terms, and so on. So you'll want to get your code book and always start in the alphabetical index first. When you're in the alphabetic index, you're looking up the names of diseases or key terms. And when you find those key terms, you're then going to be looking for any kind of guidance or dashes and such that will give you more information. For example, a dash at the end of an entry in the alphabetical index means additional characters are needed to complete that code. You will also have guidance perhaps that says C or C also, and that gives you a cross-reference to another entry that may contain more information than what you have at your original entry that you looked up. So make sure you always start in the alphabetic index first. Then you're going to want to double check that code that you found in the alphabetic in the tabular index. Now, the tabular index is the part of the code book that's broken down by chapters, and those chapters are usually lined up by body system or disease characteristics. You'll then turn over in the tabular index, find the code that you've looked up, and check for guidance. Now, guidance is additional terminology or rules that give you information about whether or not you've arrived at the correct code. You'll want to look for that guidance at the chapter level, and what that means is that when you first come to the chapter in the book, right after the code title that says, say, chapter 21, you're going to see in red perhaps or in black some writing that tells you certain information that applies to all the codes in that particular chapter. You'll also want to check for guidance at the chapter block level. Now, the chapter block level guidance applies to all the codes in that chapter block. For example, guidance that would be found at chapter block I-10 to I-15, just below that chapter block title, you'll see guidance that tells you to use additional code to identify, or it may say code also, to identify tobacco smoke use, tobacco exposure, and so on. And that guidance applies to all of the codes from I-10 to I-15. Now, once you get to the 3-character category level when you're checking for guidance, you'll want to look for guidance that applies to that category as well. For example, if you're at E10, type 1 diabetes mellitus, there may be some guidance that applies to all the codes in E10, and that's what we mean by a 3-character category. And then finally, you may have conventions or rules at the final code level itself. And that would be, for example, if you had diabetes mellitus type 2 with renal manifestations, there may be guidance at that code that says use additional code to identify the stage of kidney failure, for example. That's what we're talking about at a final code level. This shows you the importance of not only looking up a code from a list of code titles, but actually using the code book, because there's guidance throughout that book that tells you you need to use this code with this code, or you can't use these together, or you need to also use a code to identify cigarette smoke and so on. And you won't get that just looking up a code online. Now that we've covered some general reminders about coding, let's get into our complications and injury coding. Now, one of the first things when you're talking about coding complications and injuries is having a good understanding of what complications are. We have a definition from MedicineNet that we're looking at. Complications are problems that arise following and are a result of a procedure, treatment, or illness. So think about complications. Complications complicate the situation. And complication codes, when you start finding those codes, normally they're located in the body system chapters. In other words, complication codes for the respiratory system would likely be found in the chapter for respiratory system issues. Some examples of complications include infections, dehiscence, necrosis, neuroma, hemorrhage, hematoma, adverse effects of medications. Injuries, on the other hand, an injury is a harm, a hurt, or a wound. Now, injuries are coded from Chapter 19, and that's the Injury, Poisoning, and External Cause Code chapter. Some examples of injuries are things such as lacerations, animal bites, abrasions, skin tears, intracranial hematomas, and fractures. Now, complication codes are assigned based on provider documentation of the relationship between the condition and the care or procedure. What that means is that you can't just assume that the infection is due to the surgical procedure and code a complication of surgery infection. You have to make sure that the documentation you receive from the provider or the physician connects the two together. In other words, they connect the infection or whatever other injury or complication to that procedure. That guideline extends to any complications of care regardless of where the code is located. In other words, if it's in the chapter with respiratory or if it's in Chapter 19, it's still the same guideline. The physician or the provider has to document the connection between the complication and the injury or the care. Remember that your clinical record documentation must support the codes that you choose, regardless of whether you're coding diabetes or if you're coding an injury or a complication. Your clinical record documentation must support the codes you choose. That really has a lot to do with more along the lines of injuries. If you're saying perhaps that this is due to a laceration, but your documentation calls it something else. You have to make sure that those things mesh and line up and back each other up. So for that reason, the provider records, and you may have to query and do some documentation of what you found out on query in order to show that relationship between the complication and the care or the procedure, because it's not always that you're going to find that well stated. So you may even have to call and ask, doctor, is this related to that? And sometimes surgeons, as we well know, do not like to link those things because of liability, or maybe it's just not clear or whatever reason. So sometimes you can't even use these codes because you don't have the documentation to support that this is truly a complication. Let's talk more specifically about complications. You're going to see the complications per chapter blocks here. I won't waste your time in reading each of those. I just want you to see that each chapter does have a section of intraoperative or post-procedural complications of that body system. And as you can see on this slide, again, we're going through the rest of the chapters in the books. Just to illustrate again, each body system has its own intraoperative and post-procedural complications, even down to the early complications of trauma. Let's talk about some of those most commonly coded home health complications. And again, like we mentioned before, these are primarily codes such as infections, dehiscence, gangrene, fracture with insertion of orthopedic implants or prostheses, mechanical complications of devices, dislocations of joint prostheses, or transplant complications. When you're looking up codes for coding complications, we'll start in the alphabetic index. You're going to look under the keyword complication, and then once you look under complication, look at an entry for the type of complication. For example, intraoperative or post-procedural. And then once you find that complication indexed, you will double check the code in the tabular index as we outlined at the beginning of this webinar. If you're having a difficult time coding the complication, you may have to request information from the referral source as to the source or the cause of that complication or injury. For example, you may know that they have a traumatic brain injury, but in order to code that properly, you might need to know if that brain injury occurred due to an automobile accident, or a fall from a horse, or a fall down the stairs, and so on. So you may have to get that information through query. More information on complications are found in parts 2 through parts 9 of this series, as we mentioned complications in each body system in those webinars as well. Some complications that are covered in this particular part of the code book include pain due to medical devices. For example, a hip prosthesis. In my career, and I'm sure you guys have run into this as well, you might have run into a patient who is elderly and thin, and she's had her hip replaced, or he has, and that hip prosthesis continues to be painful. And in that case, pain due to medical devices could actually be a diagnosis code that's used. The other example would be an implanted baclofen pump in an emaciated patient. In the case that I saw, I had a patient who had MS, and she had a baclofen pump that dispersed muscle relaxers to her system, and she became so emaciated that the pump itself was causing pressure on her body, and that was a pain due to a medical device in her case. When you code pain due to medical devices, you'll find guidance in the code book that tells you to use an additional code from G89 to identify acute or chronic pain due to the presence of a medical device, implant, or graft. For example, the code T84.84XD is painful hip prosthesis subsequent encounter. Another complication would be transplant complications. These complications include complications in rejected organs. You would only assign transplant complication codes if the complication affects the function of the transplanted organ. And when you're doing transplant complication coding, that actually requires two codes. You have the code from T86, which is the complication category. Then you also will see guidance that tells you to use an identifying code to tell you what the complication is. For example, if you had a rejection of the lung, that would tell you to identify what that complication is. Some information and guidance to remember about transplant complications include that a pre-existing condition or a condition that develops after transplant is not coded unless it affects the function of the organ. For example, if a patient has chronic kidney disease or CKD and they have a kidney transplant, they will still have some form of kidney disease. In other words, the transplant won't fully restore kidney function if they're getting one kidney and it usually takes two to function properly. In that case, the coder would only code this as a complication. And by that I mean the chronic kidney disease. They would still have it after the transplant. So you would only code the chronic kidney disease as a complication if the provider actually states it that way. If they state that the transplant is a failure or that there's some rejection going on. Remember, always your physician must document any complications. They must call it a complication. Complication of surgery, complication of transplant, and so on. You'll find that these codes are generally listed under complications of surgical and medical care not elsewhere classified, or NEC. Some examples of that are complications following infusion, transfusion, and therapeutic injection. You may find anaphylactic reactions to serum, blood, or vaccines, complications of cardiac and vascular devices, complications of genitourinary devices, or mechanical complications of internal orthopedic devices. Okay, let's talk now about injury coding. With injury coding in ICD-10, these codes are usually associated with a seventh character. We want to briefly talk about the seventh character A, D, and S. When we first started learning about ICD-10 coding, the guidance that we heard was that we should avoid the character A in home health care. That should be used in an acute care setting. That the seventh character A means initial encounter. Active treatment is going on. What we found out after transition to ICD-10 is that CMS and the coding clinic clarified that and said it really doesn't have as much to do with the setting that the patient is in, but you really need to focus on whether or not active treatment is going on for the condition in which you're coding. What does that mean? That means in the case of, say, the patient has pneumonia and they're in the hospital and they're receiving IV therapy. That is active treatment or an initial encounter for pneumonia. If the patient then discharges from the hospital and comes home with continued IV therapy for that same pneumonia, even though the patient's in a subsequent setting, they will still be coded with an A at the end if that would be applicable to that code. And it's not really for pneumonia, but you get the point we're making here, is that if you're still treating that initial problem, you will still use A at the end of the code. If, however, this is a subsequent encounter, you would put a D at the end. And a subsequent encounter means that supportive treatment for healing is going on. Now, the best way to really illustrate this for home health would be a fracture. We know that certainly we don't actively treat fractures. By the time we get the patient with the fracture in the home, that fracture's already been set, it's been x-rayed, it's, maybe has a cast on it already. You may have some internal fixation device in place and so on. We don't actively do any of that stuff in home health. So by the time we get a patient at home with the fracture, the active treatment is over and we're doing supportive treatment for a healing process. In that case, we would have a fracture with a subsequent encounter or a D at the end for our code. We also have a seventh character S, and that is for sequela of injury. Now, what a sequela means is in ICD-9, we thought of this as late effects. In ICD-10, it's called sequela, but these are the after effects of a healed injury. So let's say that the patient had a burn on the back of their hand, and the burn has healed. In other words, it's not open, it doesn't require wound care. However, that burn has resulted in scarring or contractures, and the patient needs physical therapy and occupational therapy in order to deal with the after effects of that burn. In that case, you would code the burn with an S at the end for sequela. Traumatic fracture codes, by the way, have additional seventh character choices for the type of fracture, such as closed or open, or if it's non-healing or delayed healing and so on. So for your fractures, just remember you will have more than A, D, or S. And again, make sure you go into your code book and look for the guidance and find the box that tells you the correct seventh characters to choose from. Also, one note, A lot of people love to code dressing changes with injuries. Coding guidance tells us in ICD-10 that we are not to code any kind of an aftercare code for injury. And so dressing changes and staple, suture removal, and those kinds of codes, those are aftercare and status codes, and they are not to be used with any kind of injury code. This next slide really talks about in depth that seventh character, and I know it's a bit redundant, but it's kind of hard to wrap your brain around sometimes, so let's briefly talk about that for just a moment more. Again, remember, when you're assigning a seventh character, even though that patient might have been seen by a new or different provider over the course of treatment, the seventh character used should reflect whether or not the patient is undergoing active treatment and not whether or not the provider that's seeing the patient is seeing them for the first time. And that guidance has changed since initially we learned ICD-10 coding. Remember, again, A is for active treatment for that problem. D is for supportive treatment after active treatment when healing or recovering. And S is a complication that's a direct result of a condition, also thought of as a late effect in ICD-9. So S is sequela. That problem has healed. Some examples of active treatment as it relates to that seventh character A are wound vac therapy for dehiscence. Remember, dehiscence is not considered just a routine dressing change or aftercare. In this case, dehiscence is a complication, and it is being provided for active treatment when we go out in the home and apply wound vac therapy. So in that case, we would have the complication dehiscence code with the seventh character A in that position. Another example is IV antibiotic therapy for a post-op infection. So if we have a patient who had surgery, it's well documented that there is an infection as a complication of surgery. We're still doing IV therapy for that infection in the home. Again, you would have a complication infection, post-operative, then you would have an A for active treatment in the seventh position. When you're coding the seventh character, you need to keep in mind that each episode or each encounter stands alone. So you might have a seventh character A on a start of care and a D on a subsequent encounter or subsequent episode. For example, on admission, you may be doing IV therapy for that post-complication infection, whereas by research time, you're no longer doing IV therapy and you're just monitoring that infection status. In that case, you would have an A at the start of care and a D on subsequent encounter at a later episode. So make sure you look at what's going on with that patient's treatment to decide how to code that instead of looking at the last episode's coding. And I bring that up because quite often what we do at research time, we will just look at the codes that we put at the prior cert period, and perhaps we just carry those codes over. But when you're looking at the seventh character A, D, or S, you need to make sure you remember to look at their treatment and not the episode. When you're coding injuries, make sure you assign separate codes for each injury unless there's a combination code available that covers more than one injury. Now, traumatic injury codes are used for traumatic wounds. They're not to be used for healing surgical wounds or any other kind of wound. And I bring that up because quite often in home care, you'll see open wounds coded when it should really be a healing surgical wound or some other kind of wound. So make sure you realize that the injury codes from traumas are actually due to traumas. Superficial injuries are not coded with more severe injuries of the same site. For example, if you have a deep laceration and an abrasion of the same site, you only code the deep laceration. When a primary injury results in minor damage to nerves or blood vessels, the primary injury is sequenced first, and then the additional injuries. So if you have a deep laceration that results in nerve damage, you would code the deep laceration first, and then the nerve damage. Next, we're going to get into fracture coding and the different types of fracture coding. First one we're going to talk about are traumatic fracture coding. There are some defaults if you don't have documentation regarding what type of fracture you have. For traumatic fractures in ICD-10, they're often guided by the Castillo fracture classifications. So if you don't have that kind of documentation from your physician or your orthopedist, you can't get your hands on those notes, then there are some defaults you can use if you don't get the info you need on query. Number one, if documentation does not indicate if the fracture is open or closed, your automatic default is closed. If it's not indicated whether that fracture is displaced or non-displaced, you will code it as displaced. The initial encounter for fractures is active treatment. So again, you wouldn't use an A in home health care in this case for fractures because we don't actively do anything for the fracture. We are there after the active treatment has happened. They've set the bone or they've done whatever they need to do, and now we're just in a supportive role of ensuring that fracture heals properly. And so we would always code subsequent encounter. Remember, a treatment in this context means surgical treatment, emergency room encounter, evaluation, and continuing or ongoing treatment. And that can even be by a different provider or a different setting. Next, we're going to talk about osteoporosis fractures. A patient who has osteoporosis and a fracture should be coded to category M80 rather than a traumatic fracture code. Now, what that means is even if the patient had a minor fall or injury that would not have caused a fracture in a normal, healthy bone, we are told the default is to go to M80, osteoporosis fractures, even if that patient had a little fall. So for example, let's say you go in and you see a patient and they tell you that they had a fracture and they have osteoporosis, and you ask about how that fracture happened, and they say, well, I got weak and I fell backward on my bed and just kind of sat down hard. Well, for you and I who are not ridden with osteoporosis, if we fall back on a bed, it's a soft landing, we're not going to fracture anything. But for those patients, even a low impact fall like that could cause a fracture. So again, we're told to code those as pathologic fractures due to osteoporosis. And again, pathologic means that the fracture is due to the disease process or the disease of the bone or a neoplasm, for example. Now, if you're going to use this guidance, you must also code the osteoporosis. And another default that we have here, if the type of osteoporosis is not documented and you can't get the answer on query, your default for osteoporosis is age-related osteoporosis, as opposed to postmenopausal or those other types. Another thing to keep in mind, the patient who has osteoporosis can have a healed pathological fracture and a current pathological fracture at the same time. And in that case, your healed pathological fracture would be either Z87.310 for a healed osteoporosis fracture or Z87.311 for a healed other type of pathological fracture. If you have an injury case and the patient has multiple fractures, you're going to sequence those fractures according to the severity of the fracture, and then you would also consider the focus of care. So in this case, we have guidance that overrides the focus of care rule, and that guidance tells us to code the most severe fracture first and then think about the focus of care. Next, we're going to talk about burn coding. When you're coding burns, you should sequence the burn of highest degree first. So if you have a first, second, and third degree burn, you would sequence the third degree burn first, then the second degree burn, and then the first degree burn. If the patient has both internal and external burns, you would code the focus of care first. And if the patient has burns and related conditions such as smoke inhalation, you would sequence your focus of care first. So if you're seeing them for the respiratory issues, needless to say, the smoke inhalation would come first. If you're doing more active wound and dressing changes, the burn might go first in that case. As far as timelines for coding acute burns, there's a default that tells us non-healing burns are coded as acute burns no matter how old that burn is. So if it isn't healed, then it is an acute burn. If the burn is infected for any reason, you would also use an additional code for the infection itself. It is possible to have an active burn or an acute burn and a sequela of a burn at the same time, and you would code both when appropriate. For example, the example we gave earlier with the sequela and the burn on the wrist, if you had second and third degree burns, maybe you had a second degree burn on the forearm and a third degree burn on the wrist, and you had the second degree burn that's not healing, the third degree burn went ahead and healed, and now you have a sequela with contractures and such, you could actually have an active burn and a sequelae of a burn at the same time. Make sure also that you use external cause codes with burns. Now, again, external cause codes are usually coded on a voluntary basis. However, in this case, we have guidance that tells you at the code to use an external cause code. And when you have guidance with your burn codes, you actually have conventions at the code level that tell you to use additional cause codes with burns. And we know from studying that conventions override general guidance. So if the general guidance in this case says external cause coding is voluntary, and then you look up a code and that code says use additional code to identify the external cause, in that case you must go ahead and code the external cause. The next category in our complications and injuries has to do with adverse effects, poisoning, and underdosing of drugs. Now you're going to find this in category T36 through T65 in your drug book. One thing that's a little different about finding these codes is that these codes are coded from the table of drugs and chemicals. You still reference the drug table first and then double check in the tabular, of course, but in order to look up the adverse effects or poisoning and underdosing codes, you'd have to go to the table of drugs and chemicals, and on the left-hand side, you would see listed all of the different drugs. You'd have to find Lanoxin, for example, on the left-hand side of the page, and at the top you would find the underdosing column, and where the two intersect, that's where your code is. It's not a complete code, however. You will still need to flip over into the tabular and look to see what seventh character you need to add to the code to make it a complete code. If two or more drugs or chemicals are reported as a problem, make sure you code each unless there's a combination code listed that you can use. Let's briefly talk about what we mean by adverse effect, poisoning, and underdosing. An adverse effect is a hypersensitivity or a reaction to the drug. However, in this case, an adverse effect only applies if the drug was correctly prescribed and properly administered. When you're coding adverse effects, you'll need to assign the code for the nature of the effect first, such as tachycardia, delirium, or GI bleeding. For example, if you have a patient who's taking an anti-inflammatory drug and they end up with an adverse effect due to the drug, such as GI bleeding, you would first code the GI bleed and then you would code adverse effects of anti-inflammatory. As with any of our injury and complication codes, the physician must state that this is an adverse effect. Poisoning is sequenced a little bit differently. Remember, poisoning means there was an error in the prescription or the administration of the drug. This includes an overdose of the drug, toxicity, or drug interactions with alcohol or over-the-counter drugs. This could be an improper use of the medication. When you're sequencing a poisoning, it's a little bit different because you code the poisoning first, and then you follow that by the manifestations of the poisoning. So in this case, if the patient was given too much anticoagulants and they had a hemorrhage, you would code the poisoning of the anticoagulant first, and then you would code the hemorrhage. Unless the physician or provider states otherwise, you are to assume accidental poisoning. The reason I bring that up is when you're on your drug table, across the columns at the top, you have accidental poisoning, you have assault, and you have unknown. And so the guidance tells us our default is to assume accidental unless the physician or provider states otherwise. The third category we have is underdosing, and this one is one that we're quite familiar with in home health. Underdosing means the patient is taking less of the medication than is prescribed. This is another improper use of medication. We know that we should never use underdosing as a primary code or first listed code, and that's coding guidance. We also have guidance that tells us to follow the underdosing code that we choose with a Z code that identifies the patient's intent with underdosing. And in ICD-10, there are Z codes that identify that the patient is taking this medication because they can't afford to take the medication as prescribed, for example. Those Z codes include Z91.120, patient's intentional underdosing of medication regimen due to financial hardship. You also have three other choices. Z91.128 is patient's intentional underdosing of medication regimen for other reason. Z91.130 is the patient's unintentional underdosing of medication regimen due to age-related debility. And last, Z91.138 is the patient's unintentional underdosing of medication regimen for other reason. We have another category to talk about here, and that's toxic effects of drugs and other chemicals. This comes into play when there's a harmful substance that's ingested or comes in contact with someone. Again, we are to assume it's accidental unless the provider states otherwise. We are to use an additional code for any associated manifestations when we code toxic effects. Those are things, for example, like respiratory conditions or infections. An example of a toxic effect would be T63.331A, toxic effect of venom of brown recluse spider, accidental or unintentional initial encounter. Now that we've talked about complication and injury coding guidance, let's use what we've learned and put them to practice in scenarios. Practice scenario number 1. Patient has a post-operative wound infection with dehiscence and is sent home on IV antibiotics for 4 weeks via PICC line and VAC therapy. Query reveals the organism is group A strep. In this case, we would first code the complication, which is the dehiscence. That code is T81.31XA. This is still an initial encounter for that dehiscence. And for that reason, we put an A in the 7th position. The code title is Disruption of External Operation Wound, Not Elsewhere Classified, Initial Encounter. The next code is T81.4XXA, Infection Following a Procedure, Initial Encounter. There's guidance at T81 to use additional code to identify the infection, and that would be B95.0, Streptococcus type A, as a cause of disease classified elsewhere. And then we have 2 status codes for the PICC line and the long-term use of antibiotics, and those codes are Z45.2 and Z79.2. In scenario number 2, your patient's referred to home health care for wound care to the left upper thigh due to a brown recluse spider bite that resulted in necrosis and cellulitis of the surrounding site. Nursing is to perform VAC dressing changes 3 times a week, and the patient is taking Cipro by mouth for 10 days. In this case, we only have 2 codes. That's T63.331A, toxic effect of venom of brown recluse spider, accidental initial encounter. And then we also have to code the cellulitis, that is L03.116, cellulitis of left lower limb. In this case, the patient is taking an oral antibiotic for 10 days. However, we're really told that we should only do that if it's truly long-term, so you can use your discretion as to whether or not you want to code long-term use of antibiotics. I chose not to in this case. Practice number 3. Mrs. Parks was walking her pug in the park when she tripped on a tree root, fell, and sustained a fracture of her right wrist. She has age-related osteoporosis. Home health nursing is ordered for pain management, and OT is ordered for ADL management training. In this case, you only have 1 code, M80.031D. It's a combination code that says age-related osteoporosis with current pathological fracture, right forearm with routine healing, subsequent encounter. So we have the type of osteoporosis, we have that this is a current pathological fracture, and that it's routine healing, subsequent encounter, all in 1 code. Practice scenario number 4, Mr. Bean was trimming tree branches when he fell off his stepladder and fractured his right hip. He had an open reduction internal fixation of the hip and will need PT for gait training and nursing for medication and pain management. He has diabetes and osteoporosis, and he has a history of a pathologic fracture of L4 and L5. In this case, we have S72.001D. That's fracture of unspecified part of the neck of the femur, subsequent encounter for closed fracture with routine healing. We coded the diabetes, E11.9, because it was not stated what type of diabetes he has. And as we covered in our endocrine and diabetes coding seminar, when you don't have the type of diabetes, your default is type 2. So we coded E11.9, type 2 diabetes mellitus without complications. We also have M81.0, age-related osteoporosis without current pathological fracture. Now, the difference between Mr. Bean and the lady who fell with the pug is that Mr. Bean does have osteoporosis. However, he fell from above a standing height and had a fall that resulted in a fracture. So this is not a pathologic fracture. This is actually a trauma fracture, even though he has osteoporosis. Remember, the guidance is if the fall or trauma would not have resulted in a fracture in a person with a healthy bone, then you code it as a pathological fracture with osteoporosis. However, in this case, he did have a trauma or injury that might have resulted in a fracture for anyone, osteoporosis or not, and that's why in this case it's coded as a traumatic fracture in the S72 category instead of the M80 category. In practice scenario number 5, we have a patient who fell down the basement steps and sustained a subdural hematoma. Records indicate he was in a coma for 2 days. Following the hospital stay, he's referred to home health for PT and speech therapy for spastic hemiplegia of the left dominant side and aphasia. He continues to be a risk for falls. In this case, there's guidance that tells us we should code the effects of the hemorrhage first. So for that reason, we have G81.12, spastic hemiplegia affecting left dominant side, and then R47.01 aphasia. Then we have S06.5X5S, traumatic subdural hemorrhage with loss of consciousness greater than 24 hours with return to pre-existing conscious level sequela. But the main thing you need to remember in this case is that the subdural hemorrhage, we're not treating actively the hemorrhage. In this case, that hemorrhage has resolved, so we're treating a sequela. That's why we put an S in the 7th position on the 3rd code. We also need to remember that the hemiplegia and aphasia has to go first, and you can sequence those based on the focus of care. So if speech therapy is going more often than your physical therapy is going, you could even put R47.01 as your primary diagnosis, followed by G81.12. But in this case, physical therapy was going more often than was the speech therapist, and that's why we sequenced those first 2 codes like we did. In the 4th position, we can also code and should code the external cause code, and that comes from the Index of External Causes. That code is W10.9XXS, fall on or from stairs and steps, sequela. And it is an optional code. I went ahead and added it so that the person who reviews the claim sees that this was a traumatic hemorrhage due to a fall. And that helps to justify your therapy in this case. Another thing to know and point out here is that your 7th character should match. If you're going to use a sequela on the traumatic subdural hemorrhage and you're going to also code an external cause code, you should make sure that you have an S in the 7th position on that external cause code as well. And last, we have Z91.81, which is a history of falls. This is also the code you will use if the patient is at risk for falls. Practice scenario number 6, your patient was carrying a pot of coffee to the dining table for breakfast when her dog got underfoot and tripped her. She sustained a 2nd-degree burn of her lower left abdomen and a 3rd-degree burn of the left thigh when she fell and spilled the coffee on herself. She's referred to home health nursing for dressing changes. As we learned in our burn coding guidance, we code the most acute and the most severe burn first. In this case, we have T24.312D, burn of 3rd degree of left thigh, subsequent encounter, followed by T21.22XD, burn of 2nd degree of abdominal wall, followed by X10.0XXD, contact with hot drinks, subsequent encounter. And you notice we have the third-degree burn first, followed by the second-degree burn, and then we have an external cause code showing what happened. Remember, it's optional to use an additional T31 code for reporting the amount of body surface area. That's optional. However, it's good practice when 20% or more of the body surface area is involved with a third-degree burn. In this case, when we looked up the burn table, the thigh itself is only 9%. So we didn't have 20%, and I didn't code the additional code for body surface area affected. But you certainly could if you wanted to. Practice scenario number 7. Mrs. Jones went to the emergency room 2 days before recertification and was diagnosed with a chronic systolic heart failure exacerbation due to taking only half her Lasix and Chlorag. The ER physician states on the patient report that she cannot afford to take her medication as ordered, so she has been taking half a Lasix daily and only taking the Chlorag every other day. Nursing is to continue seeing the patient for medication teaching and setting up a medication box, and social worker is now ordered for community resources. In this case, we're coding our recert. We know with underdosing, we are to code the underlying condition first. So in our first position, we have exacerbation of the CHF. So I50.22 is our primary diagnosis, and that's chronic systolic congestive heart failure. Now, the reason that she had that problem was because she was doing an underdosing. So we have 2 underdosing codes here. T50.1X6A is underdosing of loop diuretic initial encounter, and then we have T44.7X6A underdosing of your beta blocker initial encounter. With underdosing codes, we also have to use a Z code to tell why the underdosing occurred, and we used Z91.120, patient's intentional underdosing of medication regimen due to financial hardship. I hope you've enjoyed Part 10 of our ICD-10 coding series. Again, we thank you very much for trusting us with your education and learning needs. Parts 1 through 10 of our 12-part series are on Axxess.com's website and on-demand webinars. And we look forward to meeting with you again for Part 11, which will cover status codes and Z codes.
Thank you for joining our webinar today. We know that your time is valuable and are happy you chose to spend it with Axxess. At Axxess, we're proud to offer a variety of training resources to keep you in the know on industry news and updates. You can register for additional trainings and watch on-demand training videos through our software or at Axxess.com, where you can also find tutorials, online manuals, and answers to frequently asked questions. We're always just a call or click away. Feel free to call us at 866-795-5990 or email us at support@axxess.com. All of our expert client experience representatives have a home healthcare background. They've been in your shoes and know the industry inside and out. Join the conversation and connect with us on our social channels. We'll keep you up to date with what's going on in the industry and share resources to help you grow your business and improve your patient outcomes. Thank you again for your time today and for choosing Axxess, your provider of complete home healthcare services, software, and solutions.